big welcome to this Allergy Research and Education Showcase from the National Heart and Lung Institute at Imperial College London. I'm Dr. Marta Vazquez Ortiz, the program leader of the Allergy postgraduate program at Imperial, and it's a great pleasure to be here with fantastic colleagues to talk about our education program as well as some of the latest developments in food allergy and anaphylaxis and the mechanisms and biomarkers of immunotherapy. So as you see, this is the agenda we have today. So I'm going to be talking first about the allergy prescribing education program, and then we will have Professor Paul Turner on food allergy and anaphylaxis. Professor Turner is a clinical professor in anaphylaxis, pediatric allergy and clinical immunology at Imperial. And then we will have Professor Mohamed Sanji talking about mechanisms and biomarkers of immunotherapy. And Mo is a professor of immunology and allergy at Imperial. So we're going to have about 15 minutes per talk, and then we're going to do a little Q&A after each of the sessions. So we're going to ask people to put their questions in the chat to try and be sort of quite efficient in answering to as many questions as we can as we go along. Okay, so just asking people to stay on mute. Okay. So everything works smoothly, and yeah, we're just gonna get started. So big welcome to everyone. Okay, so just sharing what we offer within the education program at Imperial, and this is very much sort of the bottom line when we have put together this program, is for you to become an absolute expert in allergy and really get the latest and the best evidence from the experts within Imperial and beyond through our excellent network of international collaborators. And why to come to Imperial? So Imperial is the top second university in the world, which is really, really outstanding. And as it says here, it's really a testament to the quality and the commitment of the entire community. So not only the academics and the faculty, but also the very talented, very motivated and very friendly students we have in the university, and also the quality of the resources that come with being sort of second best university in the world. But also, you know, allergy has been very strong at Imperial and the institutions linked to Imperial for many, many years. And it was here where immunotherapy was first attempted and published about it with Noonan Freeman over 100 years ago. And then fantastic figures like Dr. Bill Frankland in the mid-50s doing the first clinical trials on immunotherapy and setting up the first pollen counts at the top of St. Mary's Hospital, and then big figures like Professor Barry Kay, who did fantastic work into the mechanisms of T2 asthma that has then paved the way for new treatments like biologics these days. And, you know, allergy research is very strong at Imperial. We ran second in the world in that field as well, and we're very pleased that we have now an allergy centre within Imperial to really capture the excellence of the research and the education that we have here. And this is very much in a nutshell sort of the strength of research at Imperial that really goes from sort of basic science to epidemiological studies to clinical trials in a number of aspects, as you see here: food allergy and anaphylaxis, rhinitis and immunotherapy that we're going to be hearing about today, but very important, very strong in asthma, both understanding the disease as well as diagnosis and mechanisms, and then eczema and primary prevention, and with a strong component of bioinformatics and data science, trying to understand the complexity of the disease. So, and this is what positions us in a really sort of strong place to have world-class teaching and a very strong program with world-leading experts as module leads and as key faculty. And we have a very comprehensive syllabus covering sort of the whole aspects of allergy, all ages, and the very sort of multi-organ, multi-professional approach to the problem. So a very innovative way of teaching, very student-centered, very active learning approach by doing and practicing, and a very flexible format, part-time for busy professionals. And you can choose between following fully online or attending in the blended stream that includes some on-campus attendance. And it's very much a very international atmosphere where we learn from each other and we get that sort of really global perspective into allergy. And you see the pictures there of the different module leads. So we're really, really fortunate to have fantastic module leads really engaged. So our students are, come from a range of backgrounds, and mainly healthcare professionals, but not only. We have some biomedical scientists and people coming from other disciplines wanting to sort of explore entrepreneurship, industry, etc. But healthcare professionals are sort of the big group. Doctors, including pediatricians, GPs, because of this sort of holistic and multi-organ nature of the specialty, but also specialists from different disciplines that where allergy is very present, like dermatology, chest physicians, ENT, gastroenterologists, etc. But also we always have nurses, dietitians as well joining, and it's really, again, learning from each other and sort of very, very rich atmosphere. So these are sort of numbers and backgrounds from the last 5 years, with over 100 students from a range of countries, and the list kind of goes longer every year. We have students really from all over the world, again, bringing very interesting perspectives. This is the structure of the program. Is as I said, part-time, so structured in 3 levels. So starting with postgraduate certificate, you have 3 modules there. Scientific basis of allergy, which goes into sort of the details of the mechanisms and immunology underpinning allergy, where more Samji and Adnan Kustovic module leads. Then we go into the diagnosis and treatment of allergic disease, a very clinical module, very practical module. And then we finish off that first year with the cutting edge of allergy, which is all about the latest in research and helping you develop those research skills to do your own research projects. And there, Paul and Dr. Bob Boyle are module leads. And then the second year is specific modules going in more depth about the different disease areas: food hypersensitivity, asthma and allergic airway disease, rhinitis, rhinosinusitis and immunotherapy, and then allergic skin disease and drug allergy, and then complex pediatric allergy. You can exit there after diploma, say, but most of our students continue and do a research project either with us or in the local institution, and they exit with the full MSc, which is really rewarding and really nice to see. Okay, and again, you can do the whole program in the online stream, so fully online, or in the blended stream, which shares about 90% of the learning. So quite a lot of the materials are also accessible online, and part of the teaching is online. But then people in the blended stream will come on campus 3 times in year 1 and in year 2 for 1 or 2 consecutive days to do more hands-on practice and learning. So how we teach, so again, quite innovative and very sort of engaging, very sort of diverse. We have asynchronous materials, so materials that our students access in their own time, and there is a range of aspects there, so from lectures and mini lectures, but also interviews with experts, so podcasts, practical demos, a good reading list, and quite a lot of different sort of external resources, interactive exercises and tasks. And then we have live teaching online fully for the online stream, and then with some hybrid days to accommodate those students coming on campus. And that's very much for interaction, with lots of Q&As with the speakers, lots of case-based and focused discussions, and lots of student-led sessions, role play, group work, and hands-on practice for those coming on campus as well. So there's a lot of learning by doing, as I said, and everything is sort of spread out throughout the term, so things can be sort of digested at a good pace. Okay, so there are a number of assessments throughout the program, and again, these are all authentic assessments, things that you would like to probably develop and master, for your professional career. So things like writing case reports, writing review papers, presenting oral presentations, posters, writing research grant applications, running an allergy clinic or running a patient event, and then writing up your MSc thesis, which follows an original article format for a peer-reviewed journal. So very much things that we all do, or many of us do in our sort of professional work. So this is how some of the asynchronous materials look like, how you access the different sessions and the different sort of lectures. And these are some of the interactive exercises we have on a range of topics, practical demos, virtual tours into the lab, into the research unit. And then this is how the synchronous teaching looks like. So, online is very much like the meeting today, but, much more chatting from your side. And this is how the hybrid days look like, with students joining online as well as on campus. And lots of different ways to gather feedback and encourage interaction. And these are some of the on-campus hands-on practical elements we do, as you see there. So quite sort of yeah, engaging. And these are some of the clinical services that are heavily involved in the program and that feed into the program. So allergy, respiratory medicine, dermatology, gastroenterology, ENT, both covering pediatrics as well as adults, and sort of spread across London and in sort of really nice locations. We now teach either at the Brompton or South Kensington, so really, really nice locations there, very central. And what do our students do after they've been with us? So as I said, many of them are healthcare professionals with a clinical focus in their career, and they generally go into a more specialized clinical role, usually having a leading role within their service or sort of escalating positions into a different service as lead clinician, sort of consultant nurse, lead dietitian, etc. Often people build a team around them, so train the team and develop the service to really sort of provide excellent care. We have people from my GP background developing a special interest, people going to private practice, and again, people developing this multidisciplinary team around them. And being well equipped to take part in research, take part in really good quality improvement projects going forward. Some of our students go on continuing a career in research, doing MD or PhD and becoming principal investigators, and some students have had opportunities in research, again as clinical allergy research nurse or senior research fellow, or securing jobs in industry within research. Same other kind of jobs within industry and entrepreneurship as well, so more senior roles there. And these are some of the publications from students completing their MSc projects and then going to publish that. And this is just from the last sort of 2-3 years. So some of the projects students do with us, what they do at the local institutions, are really, really strong projects that then go and get published in really good journals. So some kind of practical information. So application deadlines, if you're interested in applying, do as soon as you can, because the process takes a bit of time and you don't want to miss out. For home students, which is UK and Ireland students, the deadline is at the end of August, but again, you need to start earlier than that to kind of finish off the whole application. And for overseas students, if you're planning to apply to the blended stream, because of visa implications, you need to apply by the end of July. And if you're applying to the online stream, by the end of August. The fees are on the website, so I'm not going to go in detail about that at all, but we often get questions about that. So because of how it's kind of presented on the website, so say this will be for a home student. So if you look at the full MSc fee is £15,000, but then when you look at the different steps, it's generally how people do it. So they pay 7k the first year, and then they top up with 4k, and then they top up with 3k, which takes you to the full amount of 50k you saw at the beginning. Okay, so this is just kind of to sort of break it down a little bit. We have funding opportunities, we have scholarships, partly offered by NHLI, partly by a charitable foundation, and the applications deadline is on the 2nd of June. This is open to everyone, both overseas as well as home students, so don't miss out and really sort of apply if you're interested. And there's also the Dean's Scholarship for the Faculty of Medicine, very, very appealing as well, and the deadline is on the 24th of April, so we can put the links in the chat if people are interested, but these are really sort of opportunities not to miss out. Lovely, so that's all from me. So kind of quick sort of whiz through things there, and very happy to answer any questions now, so we can allow up to 5 minutes for that. But I'm sure you're eager to hear from Paul and more as well. So I'm just gonna keep an eye on the chat for any questions for now. Otherwise, we'll move on to Paul and we can pick up any questions coming up in the chat, either in the chat or later on. Okay. Lovely. So I don't see any questions for now. So Paul, over to you. So I'm going to do a tiny bit of an introduction of, I believe many people will know you. So Paul, Professor Paul Turner, clinical professor of anaphylaxis, pediatric allergy and clinical immunology. And he has had a number of different hats and roles. I'm just going to list a few of them. He's ex-chair of the BSACI Pediatrics Committee, chair of the WOW Anaphylaxis Committee, and chair of the EACI Task Force on Food Allergy Thresholds and Severity, and joint lead of the Research Council Anaphylaxis Guidelines. So very much an expert in anaphylaxis and food allergy, and he's going to bring us some of the latest developments from his team and beyond to these meetings. So thanks so much, Paul.
Thanks, Marta, for that introduction, and good afternoon, everyone, if you're joining us from this part of the world, or good morning or good evening if you're from further afield. So I've got a short amount of time to tell you all about some of the latest happenings in food allergy and anaphylaxis research coming out of our teams here at Imperial. And actually, I think the future is looking quite bright, and I hope to convince you that over the next sort of couple of minutes. Just so you can see conflicts of interest, there isn't anything on this slide that is an obvious financial conflict with any of the topics I'll be talking about over the next 15 minutes. Now, some of you may have seen this headline from a couple of months ago, and it's a study that we did jointly with Jennifer Quint here in NHLI, where we wanted to look at the latest data in terms of food allergy diagnoses in the UK and specifically England. And there are lots of issues with sort of getting prevalence data, because you can phone up random people, which is one of the ways they do things in America, and go, anyone in the household got food allergy. But that tends to massively overestimate the actual number of people with food allergy. We can do food challenges, but they're very difficult to do at a population level. They're expensive, and not everyone wants a food challenge. And so the alternative that we did here was to use a very large National Health Service data set, so a public health data set in the UK, the Clinical Practice Research Data Link. This currently includes about 1 in 6 patients in the UK at a population level. And it includes hospital data from general practitioners in primary care. And we were able to look for codes consistent with the diagnosis of food allergy. And we had 4 different definitions, as you can see: food hypersensitivity, which is FHS, an expanded diagnosis that essentially said allergy to any food. And then we excluded things like allergy to mushrooms, which are relatively uncommon, but for some reason a very common diagnosis in the UK primary care system, and focused on the sort of the most common allergens. And then we restricted even further for whether people have an EpiPen or Jex pen prescription or not. And as you can see, we're looking at a doubling in the rates of food allergy diagnosis over the period 2008 to 2018. But what was quite interesting, that incidence, so rather than asking how many people have a diagnosis of food allergy, but actually how many people got a new diagnosis of food allergy in any 1 year period, as you can see, that actually looks like it might be plateauing off over the last 4 to 5 years of the study period. And we wonder whether that's possibly because of changes in guidelines promoting earlier introduction of foods such as peanuts into babies' diets. We wanted to look in 2019, 2020, 21 and so on, but because of COVID, the database was completely stuffed. So we weren't actually able to do that. But certainly it's quite an interesting observation there. And I've already mentioned on this that there are different ways of assessing food allergy prevalence. The criticism of the methods that we did, of course, is that it was dependent on a primary care or hospital diagnosis, and that might not necessarily be correct. We know there's over-diagnosis even by healthcare practitioners who aren't as well informed as the audience on this webinar today. And so I think we need to think about, well, what's showing an increase and what's not showing an increase? And certainly the data from around the world that seems to be showing real increases in prevalence tend to be what we call softer indicators. So self-report, prescription of adrenaline or epinephrine auto-injectors, healthcare attendance rates. But often we don't see increases in the harder markers, so rates of challenge positivity in cohort studies, or even IgE sensitization, and certainly we're not seeing that for fatal anaphylaxis. Again, some data that we published a couple of years ago, where you can see that despite quite a big increase in presentations to hospital with anaphylaxis over a similar sort of time period, actually we're getting a decrease in the fatality rate. So you're now half as likely to die from food allergy as you were 20 plus years ago. And again, that's a really important bit of good news that we need to get out there. And so I guess this all comes down to, well, what's actually driving the increase in prevalence? And I suspect that it's probably in large part greater awareness, anxiety, and concern of whether someone has a food allergy or not that explains some of the data that we've actually seen. And that's borne out by other studies as well. So this is a very Burke cohort study done in the Isle of Wight, which is a little island just off the south of the UK, over 3 different time periods. There was 1989 to 1990. There was also a study period in the mid-90s, and then a third follow-up cohort around the turn of the century. That was led by Karina Venter, who's also involved in teaching our master's programme. And as you can see here, when we look at rates of IG sensitization or indeed challenge positive food allergy, the rates are actually relatively stable. We're not really seeing significant difference over a time period. The rates do seem to go up by age, so between, from 1.2 to 1.5%, looking at this age group here, but actually certainly not an epidemic. And the same has now been reported in Australia in the various sort of health nuts and early nut studies. And these are studies that people can be very familiar with if you work in food allergy, because they're about the only significantly large birth cohort that's not where they've addressed selection bias, and everyone pretty much is getting a challenge. And one can see at the 3 time points that we now have in the Melbourne series, the latter 2 are certainly the more rigorous cohorts than the initial MAX study back in the 1990s. Rates of IG sensitization and food allergy are actually fairly stable. Again, there's certainly no evidence of some massive epidemic happening now since the 1990s. And realistically, probably the increase in food allergy happened in the 70s and 80s rather than in the 90s. Now, when we think about sort of word clouds on food allergy, one thing that I'm consistently surprised about is by how small the concept of treatment is. We're one of the few medical specialties where somehow all these other words come up more than actually getting on and treating people with allergies, and in particular people with food allergy. When I say treating, when people come to see us with peanut allergy, for example, and we say, you've got peanut allergy, don't eat peanuts, come back next year and I'll tell you the same again. That's not a treatment. That's a risk management strategy. But actually, people want a treatment. We need to do better. It may well be that more serious reactions like anaphylaxis are increasing. We know avoidance is difficult. We know accidental reactions are common. A typical peanut allergic child will have one accidental reaction every 3 years now. Reactions are unpredictable, and we know that they're rarely fatal, but we can't predict that. And so people are scared, understandably, that their kid or even themselves will be the next headline in a newspaper or on social media. And we know that adversely impacts on quality of life. And so we've got various options now for immunotherapy for food allergy, ranging from subcutaneous, which is currently still under development, vaccine treatments for food allergy, through to epicutaneous, sublingual, and oral immunotherapy. And in some way, we've been involved in the onwards development of all 4 of these modalities here at Imperial. And essentially, we're talking about exposing the immune system, the body, to increasing doses of allergen in a safe way, so that people are then, after desensitization, able to tolerate much more of the food allergen they are sensitive to than they could at the start. But we've got a paradox to allergen immunotherapy for food, that immunotherapy, especially oral immunotherapy, causes a high rate of adverse events, including anaphylaxis, and the rate of anaphylaxis is much higher for those on treatment than those who are having avoidance, our traditional treatment. And that's why we've got some large health economic outfits, including the ICER in the USA and ICFIG, which is the German equivalent of the UK's NICE, that have actually come down hard against oral immunotherapy, that they're just not convinced it's cost effective and it works. But despite this, we are overwhelmed by demand from patients and from their families for access to food allergy desensitization. And one of the interesting things is, well, actually, if OIT is associated with a high rate of adverse events that often will lead to withdrawals in 1 in 5 people who start it, are some of these other new modalities safer? And thinking about published data now, because we do have fairly good data, you can see sort of the success rates around sort of 60% with oral immunotherapy. These are the largest studies that used Palforzia, a commercial modality that's now approved in Europe, in the UK, and the USA. Sublingual immunotherapy, initially we thought was a bit rubbish. But actually, if you do sublingual immunotherapy for up to 3 years, you approach the same rates of success as you seem to do with oral immunotherapy. Although do have to flag, this study was incredibly surprising, the study by Kim et al. It was predominantly done in younger kids and infants. Or it's not infants, toddlers. And it does raise a question of whether this modality in particular is more effective in that very young age group compared to older children and adults. And then we've got epicutaneous immunotherapy, which again, after 1 year, limited success, but after 3 years is certainly in the same ballpark for 300, 600 milligrams peanut protein. So 600 to roughly about 3 to 4 peanuts as those other modalities. And certainly has a far more favourable safety profile. So I think we are increasingly coming up with options that work. And you might think, well, actually 1.5 peanuts, just 300 milligrams, that's not much. But there's good modelling data that if you can get someone from a lower threshold to 300 or 1,000, that significantly reduces by up to 99.9% their risk of reaction to everyday foods that might contain inadvertent peanut exposure. Some of you may also have been sort of hearing about the latest news about omalizumab, an anti-IgE monoclonal antibody. This has now been approved by the FDA for the treatment of food allergy, the first such monoclonal to be done so. And this initial study output from the Outmatch study in the States again showed fairly good levels of boosting tolerance to 600, 1,000, 2,000 milligrams of peanut protein with people on this monoclonal. It is a monthly injection. But if you just compare that success to the equivalent data from Palforzia using oral immunotherapy, you will see that actually it's not really superior in that respect. It is superior in terms of side effect profile, but absolutely not in terms of the clinical outcome of desensitization or tolerance. And one of the things that we now have to do in beginning to look at this is look at healthcare economics. One can see in the UK healthcare setting, we're looking around £8,000 to treat one person with Palforzia for 1 year. Even if we had capacity in hospitals for that to happen, £8,000. Homebrew, which is, using peanut off a supermarket shelf or something like that under medical supervision, potentially can be done for a lot cheaper. Omalizumab, which is, for me, almost like the gold standard, well, you can see it is much more expensive and might require lifelong treatment. And so we're now looking at some of the data that begin to come out the Outmatch study to see how we can potentially combine omalizumab with other forms of immunotherapy so that you only require a shorter course of monoclonal treatment, and yet you can benefit from the really significant reduction in adverse events that we can see when we're doing oral immunotherapy. Now, just for the last couple of minutes, I just want to sort of touch on reaction severity and the fact that, we are worried about this severe anaphylaxis. We no longer call anaphylaxis a severe allergic reaction. We call it a serious allergic reaction because we're trying to make it clear that there's this stuff here that actually isn't uncommon. It's about as common as being involved in a motor vehicle accident and turning up to hospital as a result. And that's about 1 in 200 people per year. So anaphylaxis really isn't uncommon. But fortunately, severe food anaphylaxis, where adrenaline doesn't seem to work initially, is actually pretty uncommon. And the problem that we have is that we can't identify the people who are going to have those very severe reactions easily. And we don't fully understand what it is, the mechanisms that drive this more severe phenotype in a small proportion of people. And so we're doing a study at Imperial College London, and it's wonderful that Mo Shamji, who you're going to hear from shortly, is one of the co-investigators on this study, where we're taking cases uncontrolled, cases being people who've had near fatal anaphylaxis, and we're comparing them to normal people with peanut allergy, just normal anaphylaxis, to try and spot what those risk factors are. And just to sort of whet your appetite, one thing we're looking at are the genes for tryptase production in mast cells. And you may have heard of this condition, hereditary alpha tryptosemia. Now, this is where you have multiple copies of the gene which codes for alpha tryptase. So as you can see here, this is where probably most of us are. 40% of the population has a beta beta or a beta alpha phenotype. Around 35% have a beta beta phenotype. And around 22% of the population have this straightforward beta alpha phenotype. But some people, and you can see they're sort of, 1 to 2%, will have multiple alpha copies on one of or both of the genes that code for tryptase. And this results in a higher level of baseline serum tryptase, which we think is quite a strong risk factor for more severe anaphylaxis, for venom allergy, and possibly if you have mastocytosis as well. And so in a preliminary work that we've done in almost 200 children adults with peanut allergy, it was really interesting because if we look at, well, how many alpha tryptase copies do people have? Do they have none or one or two or more? One can see that actually if you don't have any alpha copies, and this is around 20% of our population, you seem to be protected against having a severe reaction at food challenge. You might have very mild anaphylaxis, but you're not having these severe reactions that we're seeing in people who have one or more alpha tryptase copies. And certainly people with HAT don't seem to be at greater risk, which is different from what we see with venom, and raises the question of how food anaphylaxis is different from venom anaphylaxis. And it's not just us who've observed this, it's also been observed in various cohorts from America, and this is just one study out of the National Institute of Health in the States by Jonathan Lyons, where they found also that absence of alpha tryptase seems to be associated with a lower risk of severe reaction. So I'm going to stop there. I hope that's sufficiently whetted your appetite, and I think we've got a couple of minutes for questions.
Fantastic, Paul. Thanks so much for that, and you've managed to stick to time absolutely fine. That's great. So there was one question from that we received previously about what can be done to prevent food allergy in babies. So would you like that? That could be a talk in itself.
That's multiple
yours,
talks. Yeah. And you guys need to enroll in our wonderful master's program. You're getting the theme here, the author's message flashing up just to enroll. So in terms of what can be done, well, we know from studies such as the LEAP study, EAT study, the BEAT trial, and some studies ongoing at the moment in the USA and elsewhere, and also we mustn't forget about Preventadal in Scandinavia, that earlier introduction, or shall I say not avoiding allergens before 1 year of age, really does reduce rates of food allergy. One of the interesting things is that we are beginning to see the impact of genes and ethnicity on that. So, for example, the studies that the learnings from LEAP, where we only needed to introduce peanut earlier in 7 children to prevent 1 case of peanut allergy, that hasn't really worked at a population level in Australia, despite the fact we are now seeing peanut really being introduced before 1 year of age in the population there. But it is working in the white Caucasian people in Australia. It's just not working in people from Southeast Asian areas, particularly those who migrate to Australia. And so some of the work that we're doing globally, and we're working and we're talking to our colleagues over in Melbourne, is trying to understand why is it that the interventions seem to be have more efficacy in certain ethnicities and not others. Is it a language barrier? We're not sure it is that, to be honest, at the moment, according to the preliminary data that's available, or is there some sort of epigenetic influence at play here? And so there's lots happening. There are also lots of studies looking at can eczema prevention also help prevent the onset of peanut allergy. Far too much than I've got time to go into at this time. So enroll and you'll learn all about it.
Good, Paul. You presented some really nice data about all the routes for food immunotherapy and adjuvants like anti-IgE. Where do you see things more in clinical practice, say in 3-5 years' time, with potentially some more data around those modalities?
Well, I think it's getting very exciting. I'm not sure if Mo's going to be talking about some of the work that we've been doing on food allergy in his talk, but we've been working very closely with Mo to try and identify predictors of response to oral allergy immunotherapy. At the same time, Mo has also been leading some of the vaccine work internationally, looking at the development of vaccines that can be used to treat food allergy. And one in particular is virus-like particles, where we published just earlier this year in Jackie, where we've supported the clinical development of what's now moved into clinical trials phase in the USA. So it's certainly getting very exciting. I think, realistically, there is a concern over the future of oral immunotherapy due to cost. That's both cost in terms of getting the studies done and investor anxiety over whether they're going to see good returns. And also at the same time, a real issue at our end that do we really need to pay £10,000 for a pharma grade product when we can pay a couple of pounds or euros or dollars for something you can buy in a shop? And one study that we're doing now called the Natasha clinical trial is looking at the use of cheap everyday foods used for oral immunotherapy under medical supervision. Now, there's still going to be at least 1 in 5 kids and adults where that doesn't work, and we need other modalities. That might be sublingual, that might be the epicutaneous modality, or, very excitedly, it may well be the vaccine route. And there's some really interesting data on vaccines that can stimulate a tolerizing response without stimulating the IgE response that causes the adverse events and symptoms during immunotherapy.
Lovely, Paul. Great overview there. So we're going to move on. Thanks so much for joining today, Paul. And we're going to move on to Prof. Moore Samji, Professor of Immunology and Allergy at Imperial and EAACI Secretary General, amongst other hats as well. And he's going to talk about biomarkers and mechanisms of immunotherapy. So over to you, Moore.
Thank you, Marta. It's a pleasure to be here. Thanks for the invitation, and delighted to see quite a few members joining this webinar. And I hope they'll be interested in joining the course, which is very nicely led here at Imperial under your leadership. So you've given me the task to talk about mechanisms and biomarkers of allergen-specific immunotherapy, and I'll be covering this in the context of aero allergens, but also just touching a little bit more in the context of peanut allergy that Bob has nicely introduced the topic. Well, the key element here is when we're thinking about allergen immunotherapy, and particularly thinking about aero allergens or allergic rhinitis, we know that it is it's a chronic inflammatory disease of the nasal mucosa resulting upon exposure to common allergens such as grass pollen, tree pollen, house mites, and particularly has elicit symptoms such as sneezing, rhinorrhea, itching, and nasal congestion. And one of the most important elements about how it affects patients is that it reduces the quality of life of our patients. When we think about therapeutic options, of course, antihistamine works very well, and but nonetheless, it only works in around 80% of the population. So antihistamine, intranasal corticosteroids, they're all effective, but only in a majority of patients. But there's this 20% of the population where you don't see a very well clinical effect. And in those patients, of course, you have immunotherapy is indicated, and we know that allergen-specific immunotherapy is a highly effective treatment for IgE-mediated diseases, in particular allergic rhinitis with and without asthma, whether it's in patients sensitized and allergic to grass or house mites allergens. And one can administer allergen immunotherapy in 2 ways, via 2 routes, subcutaneous route or the sublingual route, and we know they both work very well. And the concept of thinking about allergen-specific immunotherapy is it's a very important aspect here, because when we think about immunotherapy, we're thinking about disease modification, we're thinking about induction of immunological tolerance and also clinical tolerance, which means we're able to give patients treatment for a course of 3 years and then induce clinical tolerance. Well, there is persistence of clinical benefit despite cessation of treatment. So what do we really understand in terms of the mechanisms associated with immunotherapy? Well, our current understanding is that in allergic individuals, particularly during the pollen season, what we have disrupted epithelium, which are releasing a lot of the mediators. You have the alarmins here, you have the TSLP 25 and 33, and these are mediators that promote and support activation of dendritic cells to be able to mature and migrate towards the adjoining lymph node once they've captured allergen, to then differentiate into a DC that is able to activate T cells, and these T cells can differentiate into a Th2 cells, Th2A cells, and T follicular helper cells. So the Th2 cells are very important because they produce alpha-4, IL-13, and the T follicular helper cells, they are even more important in this case because they produce IL-4 and IL-21, and they support B cell to then differentiate and proliferate and class switch into an IgE producing B cells, which with the release of with mast cells being sensitized to these antibodies and following subsequent exposure during the pollen season or following exposure to the allergen, one then have degranulation of the allergic effector cells. What we also have is immunotherapy, particularly what we understand is if you give subcutaneous immunotherapy or sublingual immunotherapy, the first thing we notice is the restoration of the epithelial's integrity. And then what we also see is induction of IL-10 producing IL-Cs, and we see induction of regulatory dendritic cells, which support induction of regulatory T cells, and these then further subsequently support regulatory B cell induction and antibody production like IgG1, IgG4, and we know these antibodies are very able to compete with IgE for the allergen and inhibit further effector cell activation or degranulation. One of the aspects which is very important for us and somewhat we've learned over the years is that in order to ensure immunotherapy is effective, you need to give it for 3 years. And this is a very elegant study by Professor Stephen Durham, which elegantly demonstrated that in a single center study, double-blind placebo-controlled trial of subcutaneous immunotherapy and sublingual immunotherapy, where patients were recruited and then randomized to receive SCID. This is a red line for 2 years, and then followed up for 1 year, or the green line, this patient received sublingual immunotherapy for up to 2 years, and they were followed up for a year, and then there was a placebo arm as well. These patients were followed up over the course of 3 years, and they underwent intranasal allergen challenge outside the pollen season before the study commenced at year 1, year 2, and then year 3. And what we learned from this study very nicely is that, and when we looked at total nasal symptom scores following intranasal allergen challenge, is that SCID and SLID behaved more or less the same. They were very effective at year 1, also year 2, but we lost that effect at year 3. And there was, of course, placebo effect, and this is what we see in several studies. But most importantly, what we were able to also confirm is the change in peak nasal inspiratory flow, which is a measure of late allergic response. You have effects at year 1 for both SCID and SLID, and year 2, and we lost that effect at year 3. So clearly, we know that immunotherapy is effective. SCID and SLID both at year 1, year 2, but you got to give it for 3 years. If you don't give it for 3 years, you lose that clinical effect. And of course, the challenge is in clinical trial, it's much easier to be able to enroll patients and follow them up for the course of 3 years. But in general practice, having to give immunotherapy for 3 years, there is an issue with compliance. One has to have over 40 to 60 visits to ensure that you have a full 3-year course, and one can be able to benefit from this clinical tolerance induced by immunotherapy, whether it's by SCID or if it's SLID, whether it's by tablet or drop, one has to receive it or take it on a daily basis. And the challenge we have is that the compliance for SCID is about 25%, and the compliance for SLID is about 12.5%, which makes it hugely challenging. And therefore, one has to really think about novel approaches of immunotherapy. How can we make immunotherapy better? As you mentioned very nicely in your elegant slide, that at Imperial we had Leonard Noon, who elegantly demonstrated and reported effects of immunotherapy in 1911. Now, the key here is over 100 years, and we are still struggling to ensure that we have better efficacy and compliance. So what we have to really do is we have to think about how we can improve immunotherapy, what are the measures we can take, and how best to just avoid thinking about one approach fits all, one size fits all. So what we're doing at Imperial, and this is really innovation that comes into play, we are using biomarkers, because what we've understood is the FDA, the Paul Ehrlich Institute, and the NIH in the US are very keen that we understand the mechanisms of any of the potential new therapeutics before they just go into the clinic, and how we should be able to use this as effectively for diagnosing patients, for monitoring the effects of immunotherapy, but most importantly, in terms of drug development. So biomarkers really are biological molecules that are found in the blood and other bodily fluid or tissues, and that provides a sign of a normal or abnormal process of a condition or a disease. And we use biomarkers in quite a lot in allergies. For example, biomarkers of diagnosis, specific IgE and skin prick tests, in conjunction with clinical history well taken. We know that this is how we diagnose patients. So diagnostic biomarkers, we have them in allergy. The key is to think about immune monitoring biomarkers, pharmacodynamic biomarkers in therapeutics, predictive biomarkers, and safety biomarkers, and so on. But the key really is to really think about understanding the mechanism and then coming up with biomarkers that will support clinical development and also support identification of predictive biomarkers to immunotherapy. And what really I would like to do is to just briefly talk about how we're using biomarkers in the drug development continuum, because when you perform basic research or basic science, you identify relevant pathways and so on, and you're able to have a form of a signal that you can use as a biomarkers. And biomarkers support identification of mechanisms of action, drug target selection, preclinical assessments, dose selection. This is something that I'll show you at the near the end of the talk, and they're very important in terms of clinical development, particularly from phase 1 to phase 3 trial. And most importantly, they're very useful in terms of predicting efficacy, and they can be even better than just looking at the clinical endpoints. And of course, they support acceleration of drug development. And this is where we need to really be if we were to really think that we don't have to give immunotherapy for a course of 3 years, give it for shorter, and achieve clinical tolerance and immunological tolerance. So I've got 3 vignettes here. I'll walk them through fairly quickly. So the first one is, how we've used grass pollen, 13 grass, a mixture of 13 grasses for treatment of allergic rhinitis. This was a phase 2 study. I'll show you how we use biomarkers in this case. And then how this from phase 2 we went to phase 3, and that was supported by biomarker work. And then I'll come up to the VLP work we've been doing in collaboration with Paul Turner and others globally, and how this is really paving the way in terms of thinking about novel therapeutics for peanut allergy. So the 13 grass extract is a chemically modified allergen, and it's combined with macrocrystalline tyrosine, which is an adjuvant we use and promotes induction of IgG and Th1 TALB responses, and also it's also conjugated to MPL, which also promote IgG response. So you have a chemically modified allergens here, 13 grasses, and they're sort of combined with the MCT and MPL. And this is the study that we were part in. We conducted a randomized double-blind exploratory study, and this was a phase 2 trial. The study design was 1:1, 2:2, and it was just a way of thinking about how, if you were to give immunotherapy in a conventional way, or you tweak the way that you would be giving the active treatment, can you improve the efficacy approach signal? So just to walk you through, this was a 4-arm study where you had The first arm had placebo without any adjuvant. The second arm, you had placebo receiving 4 injections, and then the remaining 6 injections of placebo with the adjuvant. And then you have a third arm that received placebo, no adjuvant, with the conventional just approach of sequential injections of the active treatment. And then there was a somewhat creative approach here where we gave an updosing of the active with intermittent placebo injections without any adjuvant, and then we evaluated the effect. So the conventional treatment was mostly injections were the first updosing were weekly apart, and then the remaining maintenance were also week apart. And the conventional were the first 3 injections were a week apart, and then the 3 injections were actually month apart, the remaining ones. And this is what really we did. So I'll move on to the next slide. And the finding really of this study was, in this randomized double-blind placebo-controlled trial, 4-arm study, a proof of concept study to move into from phase 2 to phase 3, elegantly demonstrated that the extended approach, or this rather creative way of tweaking the immune response, you are able to improve the clinical benefit, improve clinical efficacy compared to the conventional approach. We looked at several immune biomarkers. We were able to look at IgG, IgG4, IgA1, and the inhibitory activity on B cell to stimulate to promote facilitated antigen presentation. These we saw induction of this blocking antibody effect. We also looked at we identified or observed the induction of Th1 type cell responses, Treg responses, lesser to and less of the Th2 response. We conducted transcriptomic analysis on whole blood, which supported the finding towards more an immune deviation profile within the extended. But when we looked at just a normal conventional approach, it was actually the opposite. There was less of a Th1 type response and more of a Th2 type response. So clearly what we've learned here is you can tweak the immune response to improve the clinical efficacy. The second example is taking that on board and understanding that the extended approach, or the slightly more creative approach, provided a much better, superior efficacy profile. We then moved to phase 3. This was a study with 555 patients, 278 in the active and 277 in the placebo group. And just to slightly go through the study design, there were 6 injections in this study. The first 3 were a week apart, and this constituted the updosing, followed by 6,000 SU of the maintenance dose, and then there was a placebo as well, so in parallel. It was a slightly creative and adaptive trial design for this one, and pre-approved and defined by regulatory bodies. And the sample size was adapted for interim alpha spanning, which highlights that interim analysis can dictate whether we continue the study to the next season or we stopped it for futility. And just to reiterate again, this was a randomized, multi-center, double-blind, placebo-control trial conducted in Europe and US. And analysis occurred during the interim phase, and interestingly for us is that after the first pollen season, the outcome measure of the primary endpoint, the study had met its primary endpoint, so we didn't have to go to the second season. And again, 6 injection updosing on a weekly interval, and then a monthly interval of the maintenance. And this was effective, and the study had met its primary endpoint. However, you looked at it, whether you looked at the Yaki combined symptom scores during the peak season or during the entire pollen season, and whether you looked at daily symptoms or daily medications, the findings were in favor of the active treatment. We also looked at the antibody responses, IgG, and also looked at quality of life. Clearly, what we're able to demonstrate here is that the immunological responses were tweaked in favor of the active. We looked at basophil activation responses. This is the IBATs, where we are sensitizing basophils and then evaluating activation using serum from treated patients, and this was significantly reduced in the actively treated group patients over time compared to the placebo. And finally, what I'd just like to do is just to give you another example where we're moving forward, is thinking about how we can use viral-like particles to which expresses the RH2 component, and how we can use it as a sort of a vaccine approach, and perhaps see how this could be potentially used in terms of peanut allergy, a novel approach to treat peanut allergy. I won't go much into detail. Paul has nicely, elegantly introduced peanut allergy, and in terms of prevalence, clinical symptoms, and management. And I think he also elegantly highlighted the palfosia as being one of the modality, omalizumab, and also SLIT, which we know also works. But nonetheless, there is opportunity to think for other novel therapeutics, particularly. And this is where really I'd like to just emphasize, this is what we have is a viral-like particle, cucumber mosaic virus particle. It's a combination of two capsid proteins. The first one is engineered to express T-cell antigen, and then the second one is fused with another capsid protein expressing the RH2 molecule, and it has RNA which triggers TLR7 and is able to modulate the immune response. So in collaboration with Paul, we had access to peripheral blood mononuclear cells. So it was a pleasure to work with Paul and Nandini on this project, which was great. So we had access to peripheral blood mononuclear cells. We stimulated with the RH2 component or the whole peanut extract or the VLP peanut, and we evaluated the allergenicity by looking at basophil activation tests. We looked at the IgE Fab analysis here, and we looked at its effect on dendritic cells, Bregs, and T cells by flow cytometry using multiparametric flow cytometry. And what we were able to identify, which was very striking for us, and how potent this VLP peanut was, is that it was able to modulate genes in the dendritic cells towards more of a DC1 and less of a DC2 genes, highlighting that promoting and supporting DCs to support T cell differentiation to Th1 type response. So the concept of immune deviation promoted induction of IL-10 producing Bregs, induced T interferon gamma producing cells in vitro, and Tregs as well, and less of a Th2 profile. And we currently have a first in human study that is ongoing in the US, and is just coming to its the end of the trial now. And because it was an adaptive trial design, open label, we had access to be able to the data that where skin reactivity of the VLP peanut was evaluated. And again, this happened to be very safe and did not elicit any of the reactivity. So I hope what I've done is I've given a flavor to our potential students, to those who have joined, what are innovation, what advances are happening here at Imperial, and also in this topic, particularly where we are trying to move away for having to give patients and expose them to 3 years of treatment, but how we can shorten the treatment and maintain efficacy and also safety, and also how we can actually use completely out of the box novel approaches to treat peanut allergy in the future, or potentially, as Paul mentioned, use it as a vaccine, and that would be just amazing, wouldn't it? But anyway, for now, we persevere. Thank you very much, and I'd be happy to answer any question. None of this work would have been done without the team, who actually spends a lot of time and effort and dedication. I'd like to thank Janice particularly for all the hard work and pushing a lot of these projects, and also Nichelle as well, and as well as the other members of the group. Thank you.
Fantastic talk, Mo, and fantastic team there in the picture. Thanks so much for that. So a couple of questions from the audience. One is about the last product, the peanut vaccine you presented. So will that tackle just, say, RH2 sensitized individuals, so individuals who are not recognizing any of the other sort of peanut proteins? Is there a view on, could there be any sort of cross effects, or is there a plan to develop more allergens within sort of the peanut allergy repertoire?
Yeah, certainly. I think it's a very important question. What we've noticed is that some of the studies, the proof of concept studies, have shown that just by giving VLP peanut with the having expression of the RH2 molecule, you can elicit antibodies to all the other components as well. So I think that's really the beauty of it, that you don't have to express, RH6, RH1, and so on to be able to get the antibody again. So you can give one, and you have you're covering the repertoire per se.
Fantastic. And someone was asking from primary care, what are the biomarkers they were asking to select the right patients to refer for aeroallergen immunotherapy? So what would you say to that?
Yeah, it's a very important point, right? So I think the most important thing is that a very clear diagnosis is important. So physician-driven clinical history plus skin prick tests plus specific IgE to the perceived allergen. What's really important is one can do several components, but the key point is if they're allergic to let's say grass, and they not respond to antihistamine, I think that the key is very straightforward. They can be referred to, for potential allergen immunotherapy.
Yeah, fantastic. So adding to that, so yeah, like going with your basic history skills, like matching when your allergen presents the seasonality of the symptoms,
Yes,
if it is
absolutely.
a seasonal allergen, and sort of selecting those patients with more severe disease who are not responding well to sort of treatment based on your guidelines, and with good products, patients respond really well generally. So absolutely. Fantastic. Thanks so much, Paul and Mo, for the brilliant talks, and thanks everybody for joining today. So it's been really enjoyable. So we hope you like that, and get in touch if you have any further questions. Okay. Thanks so much, and have a nice evening, everyone.
Thank you, Marta.
Thank you. Bye.